Eva asked me to come and talk about teaching communication skills in the clinical setting, which is actually an area that I've conducted quite a bit of research on. I teach about it often, and I teach from the first week of medical and physician assistant school to now I spend a lot of time teaching practicing healthcare providers, physicians, nurses, etc. So moving forward, and I didn't say the disclosure thing, I suppose I'm supposed to say it, that I don't have any financial interests, no extra money here, which is okay because it's a good cause. So this is what I'm hoping in this interactive presentation you get out of it. One is just to be able to describe why is teaching about communication in clinical settings important. Two, to recognize those opportunities, those just-in-time opportunities for teaching about communication when our learners are in clinical settings. And then finally, to present a number of evidence-based strategies for how can you maximize those opportunities. So that's what we'll be spending our time going through. So there's a couple of premises to my talk that I could give a whole talk about these, but I'm just gonna assume that we all agree on these two premises. So one, effective communication is required to be an effective clinician. And we know it has impact on so many different outcomes, both for patients and families, but also for clinicians in terms of effective communication. And then the second premise that I'm going to ask you to agree upon is that you can teach and people can learn to enhance their communication. So it's not just an inborn skill, especially when we're talking about health professions, it's something that can be learned. So with that, what I want to do is talk a little bit about what we know about communication skills teaching in the health professions. And I'm going to start with the good news. So the good news is actually all over the world, and of course my perspective is from the US, but I know in many other places, communication has been recognized as a core skill for health professionals. And what that means, for example, in the US, is you have to teach and assess communication in all medical schools and all residency programs to continue to exist as a program. So that's great, and I think that happens elsewhere. We also know that increasingly, and certainly compared to even 20 years ago, so many health professional schools have curricula and really comprehensive curricula focusing on communication skills. The sort of bad news is that we know that happens with undergraduate medical students, nursing students, etc. We also know that postgraduate, so for example, residents and certainly continuing education, there is much less on offer, which is a whole other talk that we can give, but worth considering as we look at the current state of this. Now, I'm going to talk, because I work in a medical school, I'm going to focus on a lot on medical education. However, I think what I'm talking about translates to nursing education, physio education, etc. But I'm going to use medical as my example. So looking a little bit more at currently what is going on, and I can say this internationally, although different countries are different, certainly in the US. When is communication skills taught? Well, in the US, it's during what we call the preclinical years. So when our students are in classrooms and small groups before they really start seeing patients. That's good for a couple of reasons. One, it demonstrates that communication is important to the learners early, instead of saying, let's teach you all the medicine and then we'll add on communication. And two, it's really when in the curriculum, there's time to teach about it because it's harder, I think, once learners are on clinical rotations. In terms of how it's taught, and this is best practice teaching because it's communication skills, which is a behavior. You can't learn it from a lecture. It must be learned experientially. So curriculum tends to focus around either group or one-to-one practice with simulated patients, with reflection, feedback, lots of opportunities for that. That's a best practice setting. And then who teaches it? And this is a little mixed, but if you look across the board, it tends to be certain groups. So for example, primary care disciplines, which in the US would be family medicine or GPs that you talk about, or internal medicine or psychiatry, or behavioral sciences, so social workers, psychologists, etc. And what's interesting here is noting who's not teaching it. So not that many dermatologists teach it, or surgeons teach it, or critical care folks teach it. So that's just worth keeping in mind as we look at some of the problems and also some of the opportunities. So now, here's the problem, the main problem, the bad news is there have been so many studies done that have demonstrated, longitudinal studies that have demonstrated for medical students, and probably the same for other disciplines, that actually, if you look over the whole curriculum, so the 4 to 7 years, depending on your school, in the US it's 4, is that learners, they start increasing their skills as we're teaching them preclinically, but then at some point, their communication skills and their attitude starts decreasing and basically disintegrating. Now, what we see when you look at studies of this, and everything I'm talking about has a huge evidence base. I don't have references and everything because I have a giant reference list I'm pleased to share with you at the end. But what we see is the greatest decline when we see those communication skills deteriorating, like measuring them through OSCEs. If you compare them taking an OSCE right before they go on the words and in the clinics, and then you do it after they've been there a year, showing that the greatest decline occurs during clinical learning. So here's the main premise of why learner skills may disintegrate. So disintegration of communication skills and attitudes, I would argue, actually results from disintegration. So a lack of integration. We spend all this time doing formal sessions, but we don't integrate it with what's happening in the workplace. So we don't integrate it with workplace teaching. That's the problem and why it happens. And so now I want to explore this premise further and then look at what can we do about it. So I just want to tell you what we do at Iowa, and I've been in charge of our communication curriculum for longer than I'd like to say at this point in my life. We have a really comprehensive communication skills curriculum. I give the first lecture the first day of medical school on communication, and then throughout the preclinical years, we have lots and lots of small group session, one-to-one practice with simulated patients. We also send our learners to clinic periodically so they can see how these skills work in action. Then during our clinical rotations, every required rotation, and I'll show you what those are, has a formal communication session where it's small group practice with simulated patients to reinforce skills just in time that we think they'll be using. And then it's all reinforced periodically by OSCEs, so simulated patient exams, on which they get feedback. So just to show you the kinds of topics we cover, this is for our required clerkships. First, we do a transitions to rotations week, and that's where we have every single medical student give bad news to a simulated patient. So 160 students each gets a chance to give bad news and watch others. They wanted it then, even though my hope is they're not giving bad news the first day they're on a rotation, but they'll see it. And then for different rotations, we emphasize different things. So just as an example, in inpatient medicine, so that's in the hospital in medicine, that's where we think our learners are actually getting a chance to explain to patients and families what's going on, even if it might just be, these are the tests we're running today, or this is what's going to happen. So we teach them the skills for sharing information in the context that hopefully they're doing it. And so we focused on a variety of different topics depending on the clerkship, always emphasizing, well, I only want to teach them what they're going to do tomorrow. I don't want to teach them something they're going to do in 2 years because they won't remember it. So we're trying to use that just in time teaching approach. And I just wanted to put a plug in here so talking about doing all different kinds of sessions focused on different topics. This is a rather fuzzy screenshot I took of our teaching resources at each. And you can go on there and say, I want to teach an OB-GYN topic. And you can search for that. And we have had generous teachers from all over the world share their entire lesson plan, simulated patient cases, videos, everything. And the reason behind that is one of the things we know is you don't have to reinvent the wheel for some of these topics. You can first see what other people are doing, and people are willing to share their materials. So I do encourage you to check that out. I think you have to be in each member to really be able to search in there though. So, all right. So here's the problem though. So we have this incredibly comprehensive formal curriculum at my school, and other schools do too. But what we know is being in a formal session does not necessarily translate to what our learners do when they're interacting with real patients and families. Even if it looks like what they do when we assess them with simulated patients, not necessarily what they do in practice. And one of the big reasons for that is you've probably all heard of the hidden curriculum, but there's also really the informal curriculum as far as how do people learn during clinical rotations and attachments. It's not in classrooms, it's in the context of the workplace, patient care, and we know that has a significant impact on communication skills and learners' practice. I've done a lot of research in this area, and a lot of other people have too, but I thought I'd share a little bit with you because we've done interview-based studies with medical students saying, how do you learn about communication during your clinical attachments? And the main ways, they've identified 3 main ways in analysis of lots of interviews over time. So they learn it, 1, by watching their supervisors, whether they're watching residents or they're watching attending physicians. So many of you noted role modeling. They say that's one of the number 1 ways they learn. 2, they learn by just interacting with patients themselves, like taking history, sharing information. So just kind of trial and error. And finally, they learn by the feedback they get when they give a case presentation. And I'm going to use this term throughout. There are different terms depending on where you are. In the US, we just call it staffing, but I'm not going to use that here because I don't know that it's a term. It's essentially whenever a learner says to a supervisor, I just saw Mr. Jones, he's a 38-year-old man with blah, 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 and they describe what information they gathered and what they think is going on. Now, overall, in my studies and in other people's studies, what they find is during clinical rotations, and this is not just students, but residents, communication is rarely talked about. Essentially, rarely ever explicitly addressed when they look across all of their training. So I want to look at this a little bit more closely. So what I want to do is look at what are opportunities then to teach about communication when learners are in the clinical setting. And I suspect for some of you, you directly supervise learners. For others, you help support clinical teachers who supervise learners, or you're involved in assessment. So what I want to look at is role modeling, which you mentioned, staffing, which is responding to learner presentations, observing learners and giving them feedback. And then I'm going to talk a little bit about some really useful approaches that combine all of these things. So to get us on the same page, first, let's talk about role modeling. Now, what's interesting is all teachers are role modeling, whether it's their intention to do so or not. Learners are watching them interact with patients, interact with team members, etc. So if you're a clinical teacher, you are always role modeling, whether it's your intention or not. Now, what's interesting is when you ask learners, but also I've done studies with teachers where I say, how do you teach about communication? The majority of them say, well, I just hope the learners pick up on something when they watch me interact with patients and families. So I would say it's the number 1 way people think they learn about communication in clinical settings. The problem with it is often this role modeling is implicit rather than explicit. And to make that point, and I do have some of you know Dr. House on here. He's role modeling all the time, maybe not the most professional behaviors. So now I'm going to show you an example of role modeling. And what I've been told is you might want to turn the volume up on your computer. I've got it turned up here, but some people were having a little bit of a hard time hearing it. So I'm going to turn it on and I'll stop it just to see if Eva, you'll be my ears. So
Okay, so next patient says on the board chief complaint.
can you hear it?
Okay, so next patient
All right.
says on the board chief complaints a cough.
Okay.
All right. Morning,
Hi.
Miss Talbot.
Yes.
Hi, Dr. Johnson. Nice to meet you.
Hi, nice to meet you.
How are you doing today?
Oh, I'm doing okay.
Yeah,
Yeah.
I'm glad to hear that. I can see you managed to successfully navigate our confusing parking system and get to the office.
Yeah.
So you got that
I figured it out. Yeah.
I'm glad to hear that. Now that you're here, can you tell me a little bit about what's bringing you in?
Yeah, I've been having this cough that's really been bothering me.
I'm sorry to hear that. Can you tell me a little more about it?
It's been going on for a couple of weeks, and it's a lot worse at night.
Okay. What else can you tell me?
Well, I've been kind of stuffy lately too.
About over the same amount of time?
I guess a little longer maybe. Not really sure.
What else is going on? Okay. Looks like our next patient is here for knee pain, so let's go see what's going on.
Okay.
All right, I know the volume was a little low, but even if you couldn't hear it, hopefully you got the gist. Now, as you probably gathered, that is not the most effective example of role modeling to reinforce communication skills because as you see, not a lot of orientation of the learner. When he went inside, didn't introduce the learner just stood there. I didn't show you the whole interview because we didn't need to watch it, came out of the room and didn't say anything really about what had just happened and moved on to the next. The reason I wanted to show you that is when I talk to learners about role modeling, they say that is pretty much how it happens. That this is not uncommon. This is probably the most common way it happens. So what I want to do is highlight how can we make role modeling more effective and maximize the learning about communication. And there's really 3 steps that I'd like to emphasize. One is what you do before you go in the room with the learner as a clinical teacher. So doing something to essentially prime the learner. And one thing is to say, please pay attention to the way I gather the history from this person, or find out her ideas about what's going on, or demonstrate, trying to get her whole list of issues. And even offering, are there aspects of the clinical encounter that you want me to demonstrate while you're watching? So creating something for learners to focus on, because what learners tell us about role modeling, and I don't know how much it happens in Ireland, I know in the UK it does, where learners spend a lot of time just following clinicians around with the expectation that they're going to learn something. And what learners say is, I get to the point where I don't know what to focus on. And so this is just helping them figure out what to focus on. Then the middle step, and just to let you know, I'm pleased to share all of my slides with you. Eva, you can share it through your group. So you don't have to worry about necessarily capturing this. Then while in the room, actually paying attention to what it is you are role modeling, which sounds obvious, but I think sometimes people don't think about it. And then finally, coming out of the room, taking even a brief period of time to debrief and talk about what happened. Because if you just move on to the next patient, then you don't know that any learning has occurred. So some opportunity to hear from the learner what they learned or what questions they had, and even for the role modeler to reflect on what happened. Either did you see the way I tried to do X, Y, or Z, or ooh, that did not go as well as I had hoped, and talking around that. So some really simple steps to make role modeling the best educational experience it can be is the way to go forward. So I want to talk about a couple of things related to role modeling. I think it's especially useful early with learners. So we recommend when a learner starts a new attachment, say OB-GYN, that what they really appreciate is watching one of the physicians take a couple of histories to see what does an OB-GYN history look like and what do they expect. So starting with early learners, I will say I think role modeling, I end up having learners who have communication problems referred to me. And one of the first things I have them do is watch someone who's good at whatever they're struggling with patients. So time management is often an issue for our postgraduate learners. So I'll have them go and watch a clinician who is good at time management and still connects with their patients. So I think you can use it for advanced learners. I think we think of it for junior learners, but I think you can use it with senior learners. The other potential obstacle is time. I'll emphasize again that the priming, that the just saying, pay attention to how I do this, or what do you want to see, and the debriefing How do you think that went? It can take very little time. So it can be really brief. Now, a couple of things to keep in mind with modeling is what I see happen, and I don't know if it's the same where you are, but a learner will come present a case to an attending, and then the attending will walk into the room with the patient. They already know what they're thinking of. They'll ask two closed-ended, very specific questions to the patient because they already know what's going on, and they'll leave. And so basically, the communication that's being role modeled is not optimal. And that has to do with expert clinical reasoning, really, that a lot of more experienced clinicians, it doesn't take them long to kind of solve the mystery. They just have to ask a few key questions. The important thing to do when that is happening is to explain to the learner, when we go in here, I am not going to model the kind of communication skills we were talking about because you've already done a lot of that work. And also just paying attention to variable context and style, because we know communication skills vary by context in terms of, I'm spending a lot of time teaching anesthesiologists here who say, oh, I don't think I can use any of the communication skills you're teaching. And I'm like, oh yeah, you can. Here's how you do it. Right before someone goes into surgery, you still want to find out what they're worried about and reassure them. So as a teacher, just emphasizing, if you're modeling something different than core and effective communication skills, explain why. All right, with each of the ideas I'm putting forward, I'm going to say a however to it, which is, what is the problem with role modeling? And what we know is similar to any kind of non-experiential learning, like what we're doing right here today. It's limited if you're trying to develop skills. That in order to develop a skill, you have to do it. And I'm putting a few quotes in here from students as we go along. So this one said, the most teaching that happened was to watch what you see, which you won't remember because you didn't get to practice. So what we know is, for it to actually change learners' communication skills, they need to practice what they're seeing instead of just seeing it and trying to remember. So the second way I said that learners learn how to communicate is by conducting interviews themselves. And that's what they say. Once I started interacting with patients, I do well. There are some problems with this. One is you learn through, they just keep trying and seeing what works and what doesn't. But what we know, and there's fascinating literature, including by Glenn Regier, who's a great writer, and Kevin Eva, that talks about how bad health professionals are at self-assessing. So if you ask a health professional how good are their communication skills, the majority will estimate them as being much better than they are, except for the people who are probably really effective, who tend to be more self-critical. And so the ability to just look in the mirror and see who you are and say, oh, I'm good at interviewing, or I'm not good at interviewing, I have effective communication. Actually, we're really limited in our ability to do that. No fault of our own. So another opportunity then is, what happens with most learners, at least in clinical settings where I work, and I don't know if it's the same for you, is the main way we find out what happened in the room with the patient is through case presentations. So after they've seen the patient, they come to the attending and say, I've just seen John Smith, et cetera, et cetera. And so as far as clinical teaching, that is one of the main opportunities for teaching, that we respond to learners' case presentations, and that's where we teach them about medicine, about practice management, et cetera. What's interesting about it is that being the main way that teaching happens, it's received very little research attention, especially in relation to communication, which compelled me to give it some research attention. So this is what we hear from learners, that in terms of making case presentations to their supervisors, what they hear back related to communication is not really communication, it's the content. So the main feedback they get when they make a presentation about the information that they present is, what information were you trying to, or did you gather or give, as opposed to how did you gather that information, which is, when we say the how, the process, that's communication skills, less than the content. And so what they hear consistently as feedback, the only feedback they can recall about communication is, well, did you ask this question and did you ask that question? Which is not really about the process, it's about the content. And And there's nothing wrong with that. That's actually where clinical teaching should focus. I just want to point to a potential missed opportunity. Because part of what we know is the way a supervisor responds to a case presentation for learners can influence how they approach their interactions with patients. And I know you can read faster than I can talk, so I'm just going to take a minute and let you read this quote, which I think is very telling. So essentially what this is arguing is sometimes our learners can end up gathering information from patients, just thinking about, well, what am I going to present? And I've seen some who are really bad and just do it exactly in the form they're going to give a case presentation without being flexible. That's where it's the biggest challenge. But we know that if the main feedback they're getting is about, did you ask this and did you ask that, and you need to be faster, that when you look across the board, learners say, well, when I'm in a time crunch, what I let go of is my communication skills. And it turns into an interrogation to get a lot of questions answered, which we know can have quite an impact on patient care. So with this idea, part of the thing to think about is, well, if someone's giving a case presentation and you were going to give feedback about their communication skills, what would you give feedback about? And so I would like to hear from all of you, and we can just do this in chat. Can you write down what are common communication challenges the learners you work with have when they're interacting with patients, either in gathering information, sharing information, relationships? So one I could say is lack of empathy. I see that one consistently, lack of empathic statements. So I'd just be curious to get our collective wisdom here and type in at least one thing that you know you commonly see as a communication issue with the learners you work with. Where are their skills lacking? And I'll give you a second to put some stuff in the chat. Missing what the patient has not said. Nice. Lack of full attention, body language. Yeah. Not listening, body language, rushing. Responding to emotions. Absolutely. Picking up on subtle things, like what's not there or not really. Missing the relationship. So I'm seeing a lot with relationship building and empathy, and being just clinician focused with their agenda. Body language, looking at the clipboard instead of looking at the patient. Absolutely. Not probing for more information. Being just totally caught up in what question are they going to ask next and not really hearing the answer to the first question. Emotions, that seems like a big theme here. And Rita, that's funny. Panicking when the patient doesn't give the answer they want. Thanks for sharing that. So let's see, I generated a list. Let's see how much it matches yours. Oh, and think about how you know that these challenges exist, and we'll get back to that. So here's a list of common communication issues that I see that learners have. See if you recognize it. So part of it is just being organized, managing their time, not knowing what questions to ask, especially for early learners, not knowing how to deal with patients who have more than one complaint, empathy, emotion, that seemed to be a big theme in your responses, patient education skills. So when they're sharing information with patients, doing it effectively, things they can do to help patients follow recommendations. So those are some of the main ones we see. There's certainly more. Yeah, hard to listen and respond. Thanks, Margot. So what I want to look at is we have done some research, and others have, but really at Iowa, we've done a lot of this research, which in listening to case presentations, you can get cues. You get little clues to the fact that there was something going on in the room between the learner and the patient that was not effective communication. So let me show you a few examples from our research. Here's some kind of common ones that we would hear. So one is the patient had so many problems, I had a hard time sorting it out, and it took a long time. Or I started to talk about depression, but the patient was resistant, and that's all they say. And that points to, I wonder what's going on in the room. Or I explained to her she needs to take her medication regularly, which she has not been doing. And that might be pointing at, how are they sharing and encouraging that information? So what I want to do is just take this first one. The patient had so many problems. I had a hard time sorting it out, and it took a long time. So what I'm going to ask you to do is think about, see this picture here? If you were leaning on the door, listening in, or even better, if you were a fly on the wall in the room with that learner and that patient before they came and reported to you, I want you to discuss these things. In your breakout room, talk about, well, so what do you think was happening if you would have been a fly on the wall in the room? What would you have seen, either the patient doing or the learner doing? And what implications does this have about communication? So if, based on what was going on in the room, is there something you could teach them about communication in response to them making this statement?
So our group discussed maybe the student approach, and my colleague mentioned the old adage of Osler, diagnosis, 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 and that's what the students are focused on. So it tends to be a rapid round of closed questions rather than an extended statement, opening statement from the patient. So we agreed that maybe to agree priorities for that session is a really useful and powerful tool to teach students to do, and also to try and have a guiding open statement.
Okay, so maybe it was, what was going on was just a battery of closed questions from their diagnostic mind, not letting the patient talk at all, which made it go longer. Absolutely. That's one. Did anybody have other ideas of what might have been going on in the room? Anyone? Daniel?
Yes, perhaps more of a focus on content and information rather than on the patient, and then being overwhelmed with information and then being unable to prioritize what is most important to the patient just now or in the clinical presentation. Okay.
So really the idea that just focused on all these medical things, but that as they come in, not knowing how to adjust them. It's like we used to teach our students that all patients have a chief complaint, and that's all they want to talk about. And then they get on clinics and they realize, oh no, that's not true. So, all right. Does anybody else have a different idea of what might have been going on in the room? Ghazi.
Thanks. So in our group, we kind of talked about that there's probably lack of agenda setting from the point of view of the student, that they hadn't actually discussed with the patient what they were going to, what the whole session was about, what their agenda was, kind of setting down those rules at the initial beginning. So the patient was just bombarding with loads of information, not really focusing it because there was no agenda set from the very beginning.
Okay, so it's not, a lot of these are going together, and I agree. So it's not saying what are all the things we're going to talk about first. One thing I will say that some people sometimes say on this, and sometimes it's the first thing, is they say, oh, the patient was probably just really, it's one of my favorite words to say, loquacious. That the patient was talking and rambling and the patient couldn't focus. And so it's always been fascinating to me that a lot of people, I think maybe because we're all communication people, we didn't immediately jump to saying it was something the patient was doing necessarily and to what the learner was doing. So it could be any of those or a combination of what you've been talking about. And notice we've come up with lots of things just based on one statement from a learner. So it shows you how fruitful listening for those cues can be. Now let me just share my slides with you again. And I always have to redo the show video panel. All right, Eva, you can see my slides. You're my conscience. Yeah. So here are some ideas I came up with, and they just echo what you came up with, which shows what a thoughtful group this is. So here are some steps to figure out what was going on in the room. Now, what's interesting to me is people can come up with a lot of different hypotheses of what was happening in the room, but they don't know. So the recommendation is to first ask the learner. Instead of, because you might be giving feedback about something they did, or you might be giving feedback about agenda setting and it actually turns out they had a very loquacious patient. So asking them first, their perspective on what was happening in the room, and then discuss communication skills that can be helpful. And when I'm talking to clinical teachers, time is always the challenge. So you don't have to discuss all these. These are any number of things you could discuss. And I think you've all touched on most of these. So the idea of one, just listening, instead of asking questions, to doing that agenda setting, asking what else, what else, what else, until there is nothing else. At the very beginning, we know that makes encounters much more efficient and lets the patient talk. So negotiating that agenda, asking specifically about patients' ideas and concerns, because sometimes we know, especially without expressing empathy, that if patients have a concern, especially an emotional one, that they will keep repeating themselves and things take longer if you don't take the time to explore that and express empathy. And then even, you could just even suggest to the learner, what might help is just summarizing periodically what you understand so far that the patient's talking about. So here's 6 different skills that could be taught in response to a case presentation. And there are likely more. And what I say to clinical teachers is choose one based on what the learner told you is happening in the room. So it's just this idea of actually there's great opportunities during case presentations to address communication periodically, not in every single one, because of course we want to address the clinical information, the medicine, the what are we going to do. That is hugely important. It's just saying that there are moments when you get a cue that are worth, it's another opportunity to attend to communication, especially if this is the main place teaching happens. So if there are no explicit verbal cues, there are other cues that you will see. So one is you might notice that the learner was not in the room very long, or that they were in the room for a very long time. That's a cue that there's something going on communication-wise. That there might be significant information missing from the history when they're reporting it, which is a content thing, but also might be a process. Maybe they weren't asking open enough questions to get those answers, or especially the questions of what's the patient most concerned about, or what impact is it having on their life? And then nonverbal cues. If you're watching clinical teachers and a learner you'll see a learner goes to sit down with their clinical teacher and lets out a big sigh. There's a cue. Something was going on in that room. So paying attention to those. And then with no cues, you can also, as a clinical teacher, ask explicitly, how did that interaction go? Any challenges? Or what does the patient think is going on? So really pushing it through some additional questions can allow an opportunity to teach about communication. Now, I said I was going to say, however, for every model I'm putting up, I'm going to put it up and then I'm going to knock it down or tell you what the limitations are. And this one, what I'm going to talk to you about is some research that we did where we video recorded residents in family medicine with patients. And then right after that, we audio recorded what they went and told their supervising physician. So the case presentation. And we wanted to see how similar or different those were. Here's what we found. This is published in medical education or something. So we saw actually general congruence about the clinical and medical information. There were some things that weren't communicated to the supervisor, or there were some things that weren't actually elicited during the history that were communicated to the supervisor, but not that often. What we found consistently omitted is even if the learner had asked the patient about their ideas and concerns, what their social history is, et cetera, and especially if they provided patient education, they rarely talked about what they told the patient or how they told the patient about it. They just said, this is what's going on with the patient, this is what I think we should do, but didn't explain that. So that was consistently omitted from what the supervisor heard, which on some levels makes sense when you have limited time. Maybe you don't want to know all of that, and it's an opportunity. Here's the big thing we found out, that case presentations are not very good at conveying what happened in the room. So even though we talked about those potential cues, both really effective communication and really ineffective communication, by the time a learner makes a case presentation, they have organized it. So my favorite, we had this video of this totally chaotic encounter between a learner, a resident, and a father with a kid in the room. And it was crazy. It was all over the place. I don't even know how he gathered information. But then when he went and presented to the attending, it was so organized. You would never know that it was chaos and lots of closed-ended questions. And so the implications are that, even though I'm saying responding to presentations is an opportunity, there are limitations. It can only give so much insight. And what that points to is the last main thing I want to talk about, which is how important observation is. Because the only way you can tell what happened in the room is to be in the room, really. And so we know how important it is. We also know learners desire to be observed and given feedback more often. And we also know that even though all clinical teachers have been informed of this, people are rarely observed. And I can talk to learners and say, how many times were you observed with a real patient during your residency? And they might say twice. So not very much. So I want to explore this just a little bit more. And what I want to do is just talk about how do you maximize observation, and you'll recognize the format of this because it's the same as it was for role modeling. So you want to prime the learner by one, letting them know that you're not going to embarrass them or throw them under the bus, and that this is for their benefit, and ask them, what would you like me to pay attention to? And tell them what you're going to pay attention to. So if they say, you know, I've been told I talk really fast, it would be helpful to know about that. Just worth everybody knowing kind of what's going to happen with the watching. And then being in the room, the first thing you have to do is prime the patient for why are you in there and a learner in there. And what we say is for more advanced learners, they should introduce you instead of you coming in. So they should say, you know, Mr. Smith, Dr. Smith, he's here to watch me as I interact with you to help me with my communication skills. And so that person remains their patient. For younger learners, you can introduce in doing that and explaining what's happening. And then as the provider, then it's paying attention to what you're observing, and sometimes checklists can be helpful, but certainly taking notes. And the reason I'd say taking notes is because even though best practice is to debrief immediately after you watch someone, it often doesn't happen. That you get called to the next patient and you don't have time to actually give feedback till the end of the day or the next day. So I think taking some notes is helpful. And then debriefing is key. So if someone were to come and watch you at your work and not say anything to you afterwards, what would you think? Anybody have a thought what you'd think? You can put it in chat or raise your hands. Suspicious. Thank you, Maria. I think what we hear is either, oh, well, you must have done great, and so there was nothing to say with our overconfident learners. Majority of learners are, I did so badly that they're embarrassed to talk to me. And so they don't know if you don't debrief. So if you're ever going to observe, absolutely debrief and give them feedback starting with them. And this is not going to be a talk all about how to give feedback. That's a separate talk, but in general, it should be a dialogue between the learner and you, and it doesn't have to take too much time. So let me talk about time just briefly with this observation and feedback. We actually, I have to sell it to clinical teachers that they should observe learners because they're always like, I don't have time to observe my learners. So these are the advantages I sell them on. One is it can save you time because if you're listening to the history, you're doing what would normally happen in a case presentation. You're trying to diagnose what's going on with the patient. Some people sit at the computer as the supervisor and they start typing the note while they're observing the learner. So it can save time that way. It also allows you to then, right when you're in the room, if the learner missed something, to go, there's a couple of questions I'd like to add to gather more information instead of having to run from the conference room back into the patient room, et cetera. And you can, with that, you can potentially skip the case presentation because you've already heard the history for diagnosis. So it can save people time that way. There are a few other obstacles I just want to point to. So a couple other things about time. There is great research that shows watching learners for a brief period of time a few times gives you much more information than watching a learner just once with one patient for a long period of time. And so I tell people, just say you're going to be there for the first 5 minutes of the history, or after the presentation, you're just going to be there as the learner starts to educate the patient. And that can be really helpful. And then the other thing is with time, you know, the potential to video record things so you can watch it later and give feedback. In terms of I know I said learners want more observation and feedback. They also say they hate it. And it makes them nervous. And one of the things we found in one piece of research was learners said, you know, if I didn't feel like it was tied to my evaluation, if it was purely for feedback and purely to help me, and it's not going to influence my grade or something someone sees, I will be more comfortable with it. And so I would recommend separating those. And then just learners do say sometimes, you know, I get vague feedback like good job. And so if you're going to give feedback, it needs to be behaviorally specific and supportive. And we have a lot of stuff on our website about how to give effective feedback. So now I just want to wrap this up by, I said I'd talk about combined approaches, and I'm going to talk about three. One is what students recommend, which is when they start a new rotation. I mentioned this is first, they want to watch someone take a history or do whatever it is communication-wise. They'd like to watch their supervisor 1 to 3 times. And then they would like to just go have encounters by themselves while they try to replicate what they saw and kind of find their feet. And then after that, and maybe getting, maybe during make case presentations. So you can refer to those things and then observe them. So it's setting learners up for success instead of giving them feedback to say, be more like me, starting with show them. See one, do one, teach one kind of is what this particular approach is. Another way you can combine the approaches, and this is one of my soapboxes, I feel like we spend a lot of time teaching our learners how to gather information and establish relationships. And I know, not just in my school, but others, we don't spend enough time on teaching them how to effectively share information with patients. I don't know if that's the case with you. I know RCSI, Eva, you guys have such a comprehensive curriculum for your postgraduate trainees that you get to this. But that is an easy way to do it, which is the learner takes the history on their own, they present to you, and then you've kind of figured out what's going on. And when you go back in the room, let the learner start sharing the information of what's going on and next steps with the patient in front of you. So easy, takes very little time. And then you can add to it and role model some additional. And then afterwards, just debrief about how that went, what you saw them do that was effective, and anything that could be enhanced. Final model, just to highlight, and I have to say this one is, we've done several randomized controlled trials with this model, not about communication, but in general, where we compare presentations in the conference room to presentations in the patient room. So this is actually having the learner take the history and then they actually do the case presentation in front of the patient and or family. That allows real time for one, to see the learner interacting with the patient, for the patient and teacher to give feedback on the information, opportunity to role model. And what we found in our randomized control trials is it's as efficient, if not more efficient, than giving case presentations in the conference room. And patients feel like you're spending more time with them. So those are a few integrative models. Just to wrap this up, I hope I've shown you this and want to reinforce it more, which is, why should we teach about communication in the clinical setting? Well, one is so those skills we spend so much time developing curriculum on and assessing are actually reinforced by clinical teachers. Because if they aren't, smart healthcare professional students will say, I want to be like a real provider. And they never talk about communication, so maybe it's not important. Two, you can only address so much in your formal curriculum in terms of advanced communication skills like bad news telling, informed consent, shared decision making, that there are more advanced skills that are better to do just in time, right when learners are involved in doing it. And then finally, I think learners in clinical settings, that's where they're able to identify what's challenging about communicating because they've had some challenges. So that's another place you can focus the just in time teaching. All right, so here are my my big take-home points, which is just taking those opportunities to explicitly teach in the clinical setting. Role modeling and observation use those same 3 steps: priming the learner, then what do you do in the room, and then debriefing. Paying attention to those cues that come in with staffing or case presentations. I know I said I wouldn't use the word, but apparently I did. And then a way to combine those approaches.